Hello, and welcome to the session on infant and early childhood mental health and Part C early intervention. We're thrilled you're with us today and grateful to OSEP for actually having a session and sessions set aside to focus on this important area. We know that children's social emotional development and early childhood mental health, it's so critical at this point, especially in light of the pandemics we've been living over this last year and a half. Today, I'm thrilled to be joined with two of my colleagues. I'm joined with Andy Gom from the Early Childhood Technical Assistance Center and Megan Schmelzer from 0 to 3. The three of us work together on a national group that's even larger than us, that's come together to really hone in on infant and early childhood mental health and Part C and ways states can be thoughtful and intentional embedding this in their program. During our time today, we hope that you'll walk away with a deeper understanding of infant and early childhood mental health and understanding of different ways to explore those opportunities to use that within your system in your state, and also hearing from our personal journey in North Carolina. Finally, we'll wrap up with some suggested implementation strategies, hopefully that are very practical that you can take, walk away and use. So with no further ado, I'm going to hand it off to my colleague, Megan. Megan?
Thank you, Sharon. It is wonderful to be with all of you today. As she said, I'm Megan. I'm with 0 to 3. I'm on the Infant Early Childhood Mental Health team as part of the Policy Center. So what my role is today is to help you understand a little bit better infant and early childhood mental health. So we're going to jump right in. For some, this might be new. For others, this might be a refresher. But either way, I love starting with this picture. This is actually my director, Lindsay's daughter, Ren, reading up on infant mental health, ironically, in her own toddler years. So we always love to kick it off with Ren here. You can see the definition here on the screen. Some other words, though, that you might hear or have said alluding to mental health may include terms such as ACEs or trauma or attachment or social and emotional health. Either way, all are about painting a picture of how healthy relationships with adults really support the optimal development for little ones. And mental health is quite literally at the heart of it. Infant and early childhood mental health is similar to social and emotional health and well-being. There are some differences, but we really like to use that term is often used synonymously. And quite frankly, the acronym is a lot easier and better than infant early childhood mental health. So I just wanted to call that out too. What this looks like in little ones is when babies and toddlers and preschoolers are trusting and curious and persistent and self-confident and motivated. As you know, all of these characteristics support the learning and the learning process and really help to be successful in school and in life. I also want to pause for a moment and explicitly say here at the beginning that when we talk about social and emotional well-being and mental health for infants and toddlers, and really people for any age, because we all have mental health, and that is a good thing, that these concepts really are inclusive of one's racial identity, which is also actively developing in these first years of life. So when we're talking about social and emotional development and mental health concepts, we really must include race and centering racial equity as foundational points to policy and practice from the beginning. Since Part C in early intervention is all about supporting development, and infant and early childhood is mental health is the foundation for all future development, including self-regulation capacity, cognitive abilities, formulation of self-worth and self-concept, growth and language acquisition. That's why we start here. Next slide, please. There we go, thanks. So when we're talking about infant and early childhood mental health, we like to describe a continuum of relationship-based activities. From promotion, prevention, assessment, diagnosis, and treatment, we really like this visual. We like to see how this is all laid out in the system. So promotion really involves simply raising awareness of the critical nature of mental health and encouraging positive infant early childhood mental health development. Prevention can involve screening for risk factors and identifying risk factors or mitigating some of the impacts of ACEs and providing caregivers such as child care providers and teachers access to services like mental health consultation. Assessment and diagnosis really involve providing a thorough assessment and an accurate diagnosis using a developmentally and age appropriate classification, such as the DC 0 to 5. Assessment and diagnosis really should take place over a minimum of 3 to 5 visits and over a period of several weeks, just because we know how quickly these little ones develop. I also know when it comes to diagnosing, many people have many big feelings about this. And so I really also want to note that it is very important that we say that we do not diagnose the child, we diagnose the condition, which is a subtle and nuanced difference, but it's still very important to point out. Finally, treatment, as we say in the infant mental health world, is providing evidence-informed services and supports intended to directly address mental health disorders. And treatment is often aimed at supporting or repairing a primary caregiving attachment relationship. Two examples that we have around treatment are the child-parent psychotherapy, or CPP, and parent-child interaction therapy, or PCIT. We also acknowledge that there are differences. There are many differences in how we describe our work in both Part C and early intervention and infant early childhood mental health. And in the spirit of translating these two worlds, we have really included this visual to help to really help articulate that. For example, using the term treatment, I know might have different meanings in different worlds, but for us, this lands on the end of the continuum, and this is really about these services for children who have diagnosable mental health conditions. So I added Part C and early intervention here to get a visual of where this may land on the continuum because of the various opportunities that there are to embed and support infant and early childhood mental health in this work. As Andy and Sharon will talk about in just a few minutes, it really does span multiple parts of the front end of the spectrum, from promotion to prevention, and may even dip into some of the screening and assessment portion as well. I know we could probably have a longer discussion about where exactly this falls on the continuum, but broadly speaking, suffice it to say that it lands more on the front end. And as clearly, it is a critical part of the continuum, of our continuum of supports and services for little ones and the adults that care for them. Next slide, please. So I probably don't need to sell all of you on the concept that brain development is dependent on early relationships. In fact, the Center on the Developing Child at Harvard University estimates that the brain forms more than 1 million new neural connections each second in the first year of life. Stop and think about that. 1 million new neural connections each second. That's really just fascinating. And obviously that sense of urgency is very real. So we also know that since positive early experiences promote strong emotional health, negative experiences such as exposure to trauma, toxic stress, including experiences of racism, can adversely impact brain development with lifelong and often intergenerational consequences. So as Sharon mentioned earlier, because of this world that we've lived in currently, more so now than ever in the last year and a half or so, between the racial and coronavirus pandemics, we are only scratching the surface in terms of the potential social and emotional delays that children will be exhibiting as they start to trickle back into childcare homes and centers and preschools and kindergartens across the nation. Also keeping in mind that many of these adults, the caregivers, the directors and aides, the kitchen staff and bus drivers and administrators, that they are all coming back with these different experiences. And they have also experienced trauma and stress and some grief and loss over the past year and a half or so that may have impacted their capacity to recognize and meet the social emotional needs of these little ones. So now more than ever, we are in need of some really thoughtful and strategic infant and early childhood mental health specific supports to help to allow these adults to understand and care for these new and higher and more complex needs of little ones that they care for. Next slide, please. So as you can see here, we do like visuals. So here's another one for you. We've included this again to show some of the similarities and differences between these two services. We love to think of this as synergy, as looking at the increased effectiveness that results when two or more people or agencies or systems work together. There's of course, more likely more overlap than is shown in this simple Venn diagram here, but it does attempt to show the relationship between the two programs or systems. And while they have the distinct focus and values and principles, both are focused on supporting the healthy social and emotional development and preventing mental health issues in young children and supporting the nurturing and supportive parent and child relationships. So with that, I am going to hand it over to Andy to talk about some really exciting ways that you may consider integrating infant and early childhood mental health into your work. Andy?
Thank you so much, Megan. Just want to reflect on loving that word synergy that you used there, and I think that really is what this is all about today, is not what this falls on Part C, early intervention, but how can we partner with colleagues in the mental health world, with infant and early childhood mental health associations. And so I love that word synergy, and I do think it's about bringing these two fields together to effectively serve young children and their families when there's social emotional delays. So Andy Gom, I'm the past Part C coordinator in New Mexico. I'm currently consulting with the Early Childhood Technical Assistance Center at the University of North Carolina, so excited to be here with my colleagues today. I guess from the outset, I just want to say that we also know in this context of synergy and working in partnerships that we know the context looks very different for states across the country. For many of you, you may be doing a lot of the things that we're going to be suggesting or giving ideas about today, and we want to later on spotlight some of the states that are doing some great things, and you're going to be hearing from North Carolina today. But we also know the context really differs from state to state in terms of who those partners are. Some of you, there's many states that have an infant mental health association who can be a strong partner. Some states have children's mental health agencies that are very engaged. And then also things can look different even within a state, from many resources in urban areas or more resourced areas and less resources in rural and frontier areas. So just want to make sure you understand that we really know that your circumstances differ from state to state. So with that said, let's jump into this. The first area we're going to explore as opportunities is around referral, screening, assessment, and to some extent evaluation for eligibility. And in the time we have today, we're really only going to scratch the surface of some of these issues. But around referral, let's look at that first. We know that referrals of children with social-emotional delays, with risk factors, come from many different areas, many different referral sources. And so states may want to think about, and I'm sure many of you already do, think about where are those social service agencies, domestic violence shelters, homeless shelters, that may be interacting with families whose children may be at risk for social-emotional delays. We also know that child welfare is a strong referral source, and many states, if not all, were required to develop procedures back in, I believe it was the early 2000s, when the Child Abuse Prevention and Treatment Act mandated the referral of children when there's a substantiated abuse and neglect. But we know some of those procedures are now, maybe getting on for 20 years old or more. So might be a time to revisit those, but really thinking purposefully about where a referral is coming from that might identify children with social-emotional delays. When it comes to screening, we know that many states are actively doing screening or partnering with other organizations that are doing screenings, and embedding or incorporating a social-emotional screening, and we've used a couple here, Ages and Stages social-emotional has become quite popular, but there are other tools out there that focus on screening. And in a minute, I'm going to talk about the fact that some screening tools get used later on, even not just the screening for in the referral process. There is an argument to be made that Part C can also be, and we might not be doing this alone, but we might be encouraging screening around postpartum or perinatal mood disorders, or often what's called in lay terms postpartum depression or maternal depression. So that can identify families for whom some real intervention around that could be very helpful. So again, we'll revisit screening in just a second. Around eligibility criteria, we know that many states, and under Part C, it's required that states look at those diagnosed conditions, mostly medical conditions that make a child eligible. And we're saying that it's really an opportunity for states to look at that list that you have. We know that Part C itself in the federal law includes severe attachment disorder. So right there's a mental health disorder for the child that's already in the federal regs. But does it make sense to include some of the other early childhood mental health diagnoses that and include those in your diagnosed list? We know just briefly that around I think it's 6 states now, it's gone down over the years, are states that include child and family risk factors in their eligibility. But we know in the current climate with limited funding, actually the trend has been the opposite way for states having to restrict eligibility. So we're not in any way illusional that states would be moving to include at risk. But some states do include some risk factors in their diagnosed. So the line between diagnosed and risk factors sometimes is not that defined. So it might be worth looking at risk factor eligibility. So next slide, Sharon. So looking a little more specifically at assessment and evaluation to make a child eligible. Again, we know that resources differ from state to state and even within agencies that might be providing, that are part of your provider network. But we are encouraging folks to look at, does it make sense to include a mental health professional or someone with mental health expertise, or at least someone with training in infant and early childhood mental health as part of the multidisciplinary team when the referral is coming to early intervention, perhaps with a child who has social-emotional delays or is at risk for social-emotional delays, or for whom some of those other conditions or risk factors for the family, there's been abuse and neglect. So just as we might include a motor therapist on the multidisciplinary team when we get a referral around motor delays or motor concerns, we're encouraging folks to think about who's on the evaluation team that can address social-emotional development and mental health issues. Similarly, and we know also that states differ in terms of the tools that are required. There are states at one end of the continuum where the decision is at the local level. Local teams get to decide what tools they're going to use for determining eligibility, and maybe at the other end of the continuum are states where there's one tool or a couple of tools that the state has endorsed and is requiring for eligibility. So obviously there's some local context here, but it may be worth looking at whether there's supplemental tools that can focus on more specifically on social-emotional development. And this is where, again, if your state allows it, a screening tool you're not screening for eligibility, but maybe you're adding a screening tool that focuses on social-emotional development as part of the overall multidisciplinary evaluation. But we've also included some other tools here that can be used, and these will all be on your resource handout. There are also tools that more specifically focus on the parent-child relationship, and the Piccolo is one that can be used over time to look at, if we're focusing on that parent-child relationship, have we been successful over time? Or if we just use it the one time, it gives us some insight into maybe what's going on in that parent-child relationship. And then finally, Megan talked about this a little bit as maybe a tool to think about when infant and early childhood mental health treatment may be needed. The DC 0 to 5 as a diagnostic classification, and there are others out there, can be a helpful tool to look at really what's going on when the team is scratching their head or feeling like they're out of their depth. Maybe having someone either within Part C who's been trained at the clinical level to use the DC 0 to 5 or partnering with another community mental health agency to use that tool to think about what's really going on for this child and family that may be an indication for the need for treatment level services. So Sharon, next slide, please. So let's talk about what those services might be, and Megan talked about where early intervention falls in that continuum, and this carries on some of that kind of conversation. So in the intervention sort of approach, our regular early intervention folks that are working week in, week out with families, we think there's real opportunities to incorporate reflective practices, and this might be done, we're going to talk in a minute about training and workforce issues, but really encouraging families to reflect on what's going on for this family, wondering about the emotional situation of the parent and the child, as opposed to, and sometimes that means stepping back and thinking about what's going on, sometimes in the moment working with the family, sometimes those things are not, but it's bringing up things for you personally in terms of your practice. So reflective practice is really something we would encourage early intervention to think about within its early intervention model. Infant and early childhood mental health consultation is something that is being promoted in other areas of our early childhood systems, whether that's childcare, pre-K, and more often now within home visiting. Not so much within early intervention, but we think it has some real opportunities. And it may be that it's being used and that term isn't being always applied. And this is where we have someone with a mental health background, either within the team or the agency, or that's coming from another community mental health agency or another system, and making themselves available to provide consultation both to individual practitioners and to teams, and really helping them think through some of those social, emotional, and mental health issues that are going on for children and families on their caseloads, working through when a referral to a clinical level person, maybe for diagnostic work or for treatment services. So having someone part of the team or joining the team to help is what's involved in infant and early childhood mental health consultation. Many of you are probably familiar with the pyramid model or the National Center for Pyramid Model Implementation, and they have a number of tools and fidelity instruments that really look at how practitioners can work in a coaching role with families, to really partner with families, and focusing on that dyadic relationship between the parent and the child or other caregivers and the child to promote the social emotional competence. And they've really increased the focus on infants and toddlers, and some of those resources are really very helpful for early intervention. There's also another tool or approach, the FAN approach. Some folks know it's also connected to the Fussy Baby Network, which I'm not sure what I think about the term Fussy Baby, but the FAN approach is a conceptual model that really helps practitioners think about their work and reflect on their work with families, what's going on, where are they in that communication, both within each session, whether that's an hour that you have with the family, and really is a helpful model to use. So those are things at the intervention model. If you could go to the next slide, please, Sharon. So thinking about that treatment level, and again, here we're talking about that end of the continuum, where we're talking about children that have either now got a mental health diagnosis, or we know just there is a disruption to that parent-child relationship through some kind of traumatic event, abuse and neglect, domestic violence going on. So we're really talking here about a subset, a minority of children and families that would need this level. But we do think that it has some real utility. And again, here we're not saying that this all falls on Part C. Some programs do have clinical level folks that are providing some of these and able to bill within Part C. Other times it's a referral out to another, or partnering through and having those folks join the transdisciplinary early intervention team. Megan talked about a little bit about those dyadic therapy models and these really require clinical level training to be able to administer these. They're usually done over a period of time, a number of sessions. So we've just a couple of examples here, and we'll point out more on our resource page. We know through a survey that was done last year that a number of states are either providing and funding or connecting families to other evidence-based parenting models. Those often also are done over a period of weeks. Some of them have longer sessions than others. And so here's some that you may have heard of, or in your state may be being used: Circle of Security, Triple P Parenting, and Incredible Year. So, and I think Sharon is going to be talking to you about North Carolina's experience with Triple P. So then the last area, Sharon, if you could move on to the next slide around workforce. So obviously to be doing all of these things, even from evaluation and even identifying children through services, we know that we have to support early intervention folks to be able to do some of these practices. We know some states, some Part C states, have competencies that they may use for certification or recertification of developmental specialists and practitioners. So there's an opportunity to look at infant and early childhood mental health practices and embed some of those so that those are focused on as people are being certified. We know that practice-based coaching has a real opportunity to move people's practice. I think people more and more are realizing that one-time training really doesn't change practice, but it's the ongoing practice-based coaching where someone partners with the practitioner to do some focused observation, whether that's in person or through video, that then they're reflecting and giving feedback to that practitioner, and then in a very safe, supportive way, sharing goals and coming up with an action plan. And we think practice-based coaching, particularly in this work of working with families around infant and early childhood mental health, really, practice-based coaching has a lot of potential. Professional development opportunities, both synchronous, where folks are in the same room, hopefully we'll get back to that, or live video, but asynchronous, where there's modules that are available to folks, we think has some real opportunities to train folks in infant mental health. There are also, I believe it's now 30 states that have infant mental health associations, and they offer endorsement processes at different levels. And so we know many states, and I think North Carolina is going to be talking about their experience in this area. And then the last area that we think also has real potential for early intervention is reflective supervision, or sometimes called reflective supervision and consultation, where people have regular scheduled time. Sometimes this is for individuals, sometimes it's in groups, sometimes that goes back and forth, but where people really get the time that's protected to really reflect on this emotional work when you're working with families with these kind of challenges, and stepping back, as we said earlier, being reflective about what's going on and really using that time as a growth opportunity for folks' practice. So I know I've covered a lot there. I know you're excited to hear a little bit more about what this can look like on the ground, and so I'm going to hand things back to my colleague Sharon from North Carolina, who's going to be talking to you about how they're stepping along the road in some of these things, to give you those examples. So Sharon?
Thanks, Andy. So I'm just going to take a couple minutes to talk about the work in North Carolina, and it's really going to leverage kind of the framework that Andy has laid out and some of those key elements and how that looks in our state. So I'll just say that a lot of our work in North Carolina has been based on the work around our state systemic improvement plan. Our primary outcome of interest is improving social emotional outcomes, and we couldn't do that without thinking about these other infant and early childhood mental health supports. So through our SIP, we're actually implementing evidence-based practices such as family coaching, the natural learning environment practices, as well as pyramid model. We were also able to kind of assess our infrastructure and think about the different ways that we could enhance what we had to make us even stronger, thinking about this as a focus. And realizing, as Andy teed up so nicely, we have limited resources, as every Part C program does. And so thinking about what we have, what we can do within the funds, the staffing, the resources we have, and then looking to other initiatives to help support us and strengthen us. So of note, both Megan and Andy have done such a nice job, but this is just a couple of examples of ways that we've embedded it. In fact, in this last year alone, we've looked at implementing the ASQSE statewide and have had 50 of our staff trained in that DC 0 to 5. We actually have about 25 more who are really eager to pull that into our system. The other ways we've been thinking about referral in specific is thinking about state and local partners that we can be talking to ensure that folks know that we're here and we want to get those referrals, especially for those children and families who may be in challenging circumstances. Evidence-based treatments and practices and interventions are many. We have a varied pool of our personnel from, we know our service coordinators, those that provide special instruction, to our clinical staff. And so with that, we are actually launching pyramid model this year. We also in North Carolina are a triple P state. So there was a lot of work that has laid the foundation for that in our state. And we're very privileged to have a strong infrastructure outside of our system, but many of our staff are trained in triple P. We also have those trained in parent-child interaction therapy and child-parent psychotherapy. An additional training we've started to embed or make available to our staff is Circle of Security as well. Workforce development is something that's so important to us, not only because of our federal regulations of having a comprehensive system of personnel development, but also, again, increasing the capacity of our workforce to focus on this area of social and emotional development and infant and early childhood mental health. As Andy referenced, we are actually one of the states that recently has joined to bring the infant mental health endorsement to our state, and we're thrilled. We're looking at ways and planning for ways where our staff can be endorsed, and also looking forward to using the competency guidelines in the work we do. Fortunately, there's already a crosswalk with the competency guidelines and pyramid model, which helps us get a good way there. We also have extended opportunities for additional training and always seeking ways that we can strengthen our workforce and through the ways synchronous and asynchronous. And in ways where North Carolina may not have those resources within our Part C program, we have also been exploring different partnerships and collaborations outside of our system. One specific example is we've partnered with the North Carolina Psychiatric Access Line, which looks at bringing in trained behavioral specialists, mental health clinicians, psychiatrists, psychologists to help support the medical community. However, they're extending that model and working with us. And so through that, we're looking at ways to bring in those specialists to help us with assessments, evaluations, and or even joining our team. So that was a quick run through, but we know the time is short together. So I'm going to hand it back to Andy just to talk about partnerships and get us to wrap up the session for today. So Andy?
Thanks, Sharon, and I know a lot of your colleagues across the country will be eagerly emailing and calling you to find out how you did some of those exciting things. But as we said earlier, we know that Part C states can't do this alone, so we don't have much time, but here's some different ideas around partnerships and collaboration. But also, I think we're at an exciting time around funding. We know that there's an injection of federal funds through preschool development grants and the American Recovery Plan. Sometimes there's other federal funds through SAMHSA, and sometimes even this is an area that philanthropy foundations in your state may be willing to fund. And maybe there's already collaboratives that you can join within your state. So, but we've thrown a lot at you today. If you could go to the next slide, Sharon. We'll be having further conversations and further resources, but I think one thing we'd like you to take away is to not be overwhelmed with all of what we've presented today, or even seeing all of the exciting things happening in North Carolina, but maybe think about the last bullet here, the low-hanging fruit. What are the things that you might be, while you maybe want to do a lot of them, They can take time. We know initiatives are labor intensive, time intensive, but what might be some things? Is it adding a screening tool focused on social emotional? Is it inviting a mental health person to your conference that may be coming up next spring? So what are the things that you can do in the short term that are low-hanging fruit that you might move forward with? But here's some other ideas, and we'll have these in the handouts. So Sharon, I'll hand things back to you to wrap us up.
So thank you, everybody, for the time. Again, as Andy just mentioned, we will have our handout that has all the references and hopefully more, and you will have access to these slides as a reference. One other thing is stay tuned. There will be a paper coming out that will go deeper and wider in ways to strengthen your Part C program or Part C programs in your state around infant and early childhood mental health. So thank you again for your time. Be well, stay well.
Thanks, everybody.
Thanks.
Thanks. See ya.